Ladies and gentlemen, thank you for standing by and welcome to the Becoming an In-Network Provider, the Health Department Perspective, presented by Scott Coley, Robin Isler, Vicki Poirier, and Sharon Gates, and NACCHO staff. During the presentation, all participants will be in a listen-only mode. However, you may submit questions to the speaker at any time today by typing them through the chat feature located to the left of your screen. Questions will be addressed as time allows. As a reminder, today's call is being recorded. Today's first speaker is Rebecca Gehring from the National Association of County and City Health Officials. I would now like to turn the call over to Rebecca Gehring. Please go ahead, Ms. Rebecca Gehring.
Good afternoon, everyone, and welcome to Becoming an In-Network Provider, the Health Department Perspective. We're really excited about today's presentation. First, we'd like to thank our funders, the United States Centers for Disease Control and Prevention, who have made this webinar possible. And we'd also like to specifically thank the National Center for Immunization and Respiratory Diseases, Billables Project for Health Department Immunization Services, and the National Center for HIV, AIDS, viral hepatitis, STD, and TB prevention. Today, we have our speakers. We have Scott Cooley. He is the Immunization Billing Coordinator from the New York State Department of Health. He has served in this role since 2010, where he advises local health departments on billing issues and how to implement billing. He has a master's degree in virology and public health. Our next speaker is Robin Isler. She's the unit administrator from the Central Valley Health District in North Dakota. She has over 15 years of experience in public health, including billing for clinical services, maternal child health care, adolescent health programs, family planning, immunizations, tobacco, and emergency preparedness. She has a nursing degree from Jamestown College. And finally, Vicki Poirier and Sharon Gates from the Mississippi State Department of Health Billing Project. Vicki is the billing coordinator, and Sharon is the lead analyst for the project. Both women have detailed experience in the Mississippi Patient Information System. And we also have Alyssa Kitlis from NACCHO and myself that will be presenting later today. So today's agenda is as follows. We're going to look over the billing landscape and the contracting overview. Then next we'll look at the decentralized perspective, the centralized perspective, and then we'll go over the NACCHO Billing for Clinical Services Toolkit. Here's the next slides are the presenters' bios, which are more detailed and you can read a little bit later. Thank you again for joining this call. I would like to turn over the presentation to Scott Cooley, the Immunization and Billing Coordinator of the New York State Department of Health. Scott, please.
Thank you, Rebecca. Hi, this is Scott Coley from New York State Department of Health. I'm going to talk a bit about the billing landscape and specifically hone in on a few points of our experience here in the state of New York. First, just a little bit of a background on networks for health insurance companies. The networks are groups of medical providers that are contracted by the insurers to provide services for beneficiaries. These are providers who provide the range of the needs of medical services that those benefits require. This is particularly a feature of managed care, and it allows insurers to control member service access and the rates that they pay for those services. Those providers who are not in a network may receive either reduced reimbursement or no reimbursement at all from particular insurers, depending on the policies of those insurers. And since we're talking about health departments, this has not historically been an important part of the business of public health, but as we get further, particularly into the Affordable Care Act, it is becoming an issue for local health departments, and it's becoming part of the core business of a local health department. So what are the rationales for contracting and billing? First of all, local health departments are the public health safety net. And as public health resources are decreasing and fiscal accountability increases, we need to look into how to make county health departments sustainable. Of course, there's a subset of patients that have no financial access barrier. They may be accessing health services at county health departments or local health departments because they're more convenient, or because they're unable, or perhaps because of confidentiality issues, they do not wish to go to their normal care provider. And it's important for county health departments to remember, particularly with those patients that do not have a financial barrier, that costs otherwise not reimbursed are absorbed in New York State, in particular by county tax dollars, and for all of us by state tax dollars, and of course by federal tax dollars. Just an overview of the process of contracting to enter a health insurance network. This is the process of establishing the agreement. It details the services that are to be provided, the reimbursement rates for those services, the time frame in which the provider has to get claims submitted to the insurer, and other obligations between each party. And negotiation of these contracts may take months, and in most places, contracts are not guaranteed. It's up to the insurer to negotiate and agree to a contract with their providers. So the question for a local health department is to contract or not to contract. In many cases, it's going to be to contract. If you are serving patients with insurance, be it public or commercial insurance, either you do not wish to bill patients out of pocket, or in the case of public insurances, you cannot bill patients out of pocket. And in particular, with contracts, using the insurance would mean more reliable reimbursement. You know, based upon what the contract dictates, how much you're supposed to be paid by the insurer. And it gets rid of billing patients either out of pocket at clinics or by statement after they leave the clinic, which is a very inefficient method of getting reimbursement. Or not to contract. Some health departments may find, depending on their patient population or the insurers with whom they're working, that it's not necessary to contract. In some cases, there are local policies or regulation allowing non-network claiming. In New York State, we've been working on a particular example where Medicaid managed care companies are required to reimburse local health departments. And that rate is also set in their contract between the Department of Health and the insurers. It's important for each local entity, state or county, whoever is responsible for the contracting, to be aware of the local policies and regulations. So there are actually a good number of benefits to local health departments in joining a network. As I already stated, reimbursement you get either at higher rates or at least at more reliable rates. And if you're claiming out of network, your claims may be not denied. And you're able to keep serving the patient population that you were serving before Affordable Care Act. The idea with the Affordable Care Act is that we will see more people, more individuals, families, employees served by a more robust insurance. And that may mean that some of your patients who are not used to accessing medical care through other routes may come to you with insurance. And particularly with these insurance changes, you as the public health provider can help patients, clients, to understand their insurance plans, their deductibles, copays, and out-of-pocket expenses. As an in-network provider, you'll gain a better understanding of what the insurance company requires, and you'll also be able to provide services with fewer of the deductibles and copays and out-of-pocket expenses associated. And of course, contracting is the first step in terms of financial sustainability for local health department programs. It's easy to forget about the benefits that insurance companies gain from the services that public health departments provide. And it's important to remember that they gain some of these benefits whether they have you in their network or not. You provide excess service capacity. You bill for limited services, so they're well-defined services. In New York State, a number of our counties now only provide immunizations, or immunizations, STD, and TB services. They're very well defined, and they're quite limited. This can provide network adequacy in terms of the number and type of providers in their network. And local health departments do assist in linking members, particularly the members who have access issues because they have not been linked up with the system, to gain access to the system of primary care providers. They assist in getting new clients. We've had facilitated enrollers, now we're moving towards navigators. That actually gives the insurance companies more business. And of course, health plan quality data. The services that are not billed for, if a county health department, a local health department is providing services and not billing for those services, the insurer will never get that data. And so they will not have the data for quality reports, be they national or state quality reports. There are a lot of realities which affect contracting and joining of networks, particularly as we're going to be discussing further in this webinar, centralized states versus decentralized states. In New York, it's a decentralized situation, so each of our counties has the responsibility, and they go out and do the contracting. Insurance laws. We have, some states actually have a law referred to as any willing provider. New York State does not have the benefit of this. In any willing provider states, any provider who will accept the terms of an insurer's contract can join that network. In New York State, the insurers can turn providers away if they do not feel that they're needed, and that includes local health departments. We have particularly one insurance company that turns just about every local health department away. There may also be laws or public contracts, like the contract between Medicaid managed care companies and the Department of Health. Such laws or public contracts that impact health department billing. There's also government sovereignty, which really affects some of the details of the contracts. In essence, what that means is that state and local governments will not agree to certain stipulations in contracts, particularly if the insurance company stipulates liens on property of the contracted entity. So that's one thing that needs to be worked out between public entities and insurance companies. There are a number of procedural barriers to local health department contracting. Some of these are just details that need to be addressed in the negotiation process, the non-financial negotiations. timely filing of claims is one that I'll pick out here. It may take you as a public health provider longer in order to get your claims submitted than it might take for some other providers, and it's important to take that into account when you are contracting. The last bullet here, contract entity, health department versus medical director, is another important point. While many insurers will recognize a health department as a provider entity, some require that the medical director be the contracted entity. And that has caused problems with a number of our county health departments where the medical director has outside practice. And so we've had to work, our county health departments have had to work with their medical director and with the insurance companies in order to get those issues sorted out. As my final points, I'd just like to highlight the communication disconnect with private insurance. Insurance companies are not focused on public health, and even if they say that they understand what public health is all about, they generally do not, or there are certain things that they just don't understand. Some of our more successful health departments, county health departments in New York, have insisted that by getting an insurance contracting representative to visit their health department, that helps the conversation, that helps them understand what's going on at a health department. Health departments don't fit easily into any provider category, and there's often a mix of non-billable or non-traditional services that fall into the palette of services that health departments provide. Particularly with immunizations, which is what I focus most on, we're working with nursing services and the use of standing orders. There's no physician who directly sees the patients in most cases, and therefore there has been a bit of a conversation in making sure that standing orders are valid and those claims are reimbursed. Of course, we hear, even in cases when health departments are contracted with insurers, periodically we hear of claims that are denied because public health equals free. And we have to change that paradigm. Public health is there as a safety net. Public health is available for those who need it and have no means to pay. And there are metrics for ensuring that those who can pay do pay, and those who cannot pay receive subsidized or free services. It's not the same thing as free. And also, frequently we hear about reimbursement rates that insurers offer that are not in line with the costs of serving patients. And it's important to educate the insurers that that health departments cannot charge more to one patient or for one service to make up for a shortfall for another service. So I would summarize by saying, get the insurance to send a representative to your health department and take your contracting one insurer at a time. Determine whether a particular insurance is important for you to contract with, and spend the time to educate them and get into their network. I'm going to hand it back to NACCHO.
Thank you, Scott, for such a great presentation. Our next presenter is Robin Eisler from the Central Valley Health District in North Dakota. Welcome, Robin.
Hi, thank you, Rebecca. So North Dakota is a decentralized state. We have 52 counties in North Dakota and 28 local health departments, and they vary in size and degree of expertise in order to work with contracts and insurance companies. We have been working together as a group. We share a lot of lessons learned amongst each other, and I think that that has really helped our experience in North Dakota. So as you begin this journey, I am going to talk a little bit more about getting into actually some of the terminology, some of the logistics of contracting and credentialing. And it is a new field out there for some of us in public health. We weren't trained in doing this type of work, and there's a lot of terms that we need to start to be familiar with. And I think learning the language of insurance companies is a challenge. And so on this first slide, you see there's participating, there's non-participating, there's in-network, there's out-of-network. PAR means participating, and those are really the people who have entered into an agreement with a health insurance carrier. Very easy. Non-participating is not participating, or you've declined to do that. And there really are benefits to both of those. As a health department, you really have to look at what services you're providing. In my agency, we usually look at the larger health insurance plans where we have the most members that might participate in those plans to determine those are the ones we want to contract with. For example, we have North Dakota Blue Cross Blue Shield, we have Medica, we have a Sanford plan. So those are some of the ones we are currently working with. There are also benefits to the client, whether you're an in-network or out-of-network. So they have to look at that as well. The one term I want to point out here is the word medical necessary. As you get into contracts, you are going to see this term. And medically necessary means that the services that are paid are usual and customary. So an example of this would be we provide immunizations and we bill for immunizations at our health department. We do those based on the HIP guidelines. So we are providing immunizations that are approved by the Advisory Committee on Immunization Practices. And so that would definitely be a medically necessary service that we provide at our health department. But you will see that term in contracts. Some other things to consider are balance billing and fee-for-service. Balance billing happens when local health departments bill the clients for the difference between what they charge and what the allowable amount is. Some contracts between insurance providers don't allow you to balance bill, and a provider who accepts assignment agrees not to balance bill the client. One example of this would be Medicare. We bill Medicare for flu shots for our clients, and we agree to accept assignment for the flu shot, and we agree to accept the payment that Medicare will pay. Fee-for-service seldom pays 100% of what providers charge. The allowable amount is the price that the insurance company will pay for that given service. And sometimes you can negotiate that fee schedule, and sometimes it's based on what's usual or customary in a certain demographic area. So what an insurance company might pay here in North Dakota may not be the same as what they pay in New York. Most likely it will not be. One of our examples that we found in North Dakota with our Blue Cross Blue Shield is that the contract stated that we had to accept what insurance would provide for immunizations, that we would collect any co-pays or fees, that we would write off any provider discounts, and that we would need to bill the client for any out-of-pocket expense. So those are just some things that you may need to consider when you're looking at signing a contract. There are many things you're going to need as you start to work through the contracting process. A lot of documents. And this is kind of a list of some of those documents that you will have to have in order to submit your contract. And those are certainly any agency certifications and license, provider numbers, credentialing of staff, mainly your medical providers like a physician, nurse practitioner. You may need to provide some credentialing for nursing staff. What kind of documentation do you have in your organization? That's important as part of the billing process, is to have charting of the services you provide. You need to have some familiarity with coding. It is also very helpful to have verification of client eligibility, whether you can do that via phone and type in the client's number so that you can verify and you know what the insurance will pay for their service that day. You will also need to be able to accept electronic payments into your own bank account at the health department. Many times we do not receive a paper check for the insurance claims that we have filed, so you have to be able to receive those payments electronically. You will, however, get a copy of a benefit so you know what to write off and what to apply to a client's account. A little more on contracting. When you first decide to go and contract with an insurance company, you really establish some sort of a go-to person in the insurance agency. That is very helpful. And write their name down and keep that next to the phone number so that you can touch back to that person as you go throughout the contracting process. It's also very important to have someone in your agency as the go-to person to do the contracting process, because they'll be more familiar with the steps rather than having multiple people involved. Some of the things you may not have as a health department are listed on this slide. State license, local business licenses, certifications, accreditation. One of the ways we are getting health departments accredited across the country, but a lot of us are not that. So one of the ways that we did show an accreditation or some sort of a inspecting visit was to use our Vaccine for Children program. The state comes out and does a site visit, and we were able to use that visit as part of our accreditation process for the contracting with one of our insurance companies. So that was helpful. So you can kind of think a little outside the box. Many times when I'm on the phone with insurance companies, I say, I'm a health department. I'm not a clinic. I'm not as familiar with the process, and just clarify what it is that they are needing, because it is a different language. It is something I'm not familiar with. Some other things before you go and contract, and some things you might want to consider. As I mentioned before, we look at really like our larger employer groups in our community and what insurance plans they have, and we try to concentrate on those insurance plans. Especially with immunization, we also do bill with our Title X family planning program. We do, however, have to sort of have that separate. There are really two different organizations within our agency, so it can involve two contracting processes when you're doing that. You also want to know, does the insurance plan require that you take a certain number of patients? How are they going to pay you back? Is it based on the full fee or a fee for service or discounted fees? And you want to think about how much revenue your health department will generate from having a contract in place. It may be helpful for you to verify the client's eligibility into insurance, and is that easy to do? And what is the capacity of your staff? In North Dakota, as I mentioned, we have very small health departments, and they do many, many things. And so do they have the capacity to take on this billing process or with an insurance plan? Credentialing. This is another lengthy part of the contracting process, and it requires gathering many documents for those providers that you will be billing with. As Scott mentioned, many of us have a medical director or a physician or maybe a nurse practitioner in the family planning program, and they are really the ones who the credentialing process is meant for. I have not really seen too many instances where nurses themselves are credentialed, although that can happen as well. But listed there is several of the items that you will need in order to provide the credentialing information. I want to draw attention to the last item when billing under the medical director. These are some other internal documents that you may need to have as you, just for the workings of your health department, and that is signed physician orders that allow your nursing staff or others to provide services, your policy procedures, the physician's DEA number, and just good communication with that medical director. Many times they're not located within the health department. They might just be there as the overall over your agency, but they're not actually in-house. So those are just things you need to consider. There are a couple credentialing services that are available if you do plan to do multiple contracts and multiple credentialing. These services are available. You can do a one-time application for credentialing, and then that way when you contract with other insurance plans, they can go to these services and the credentialing has already happened. So you won't have to gather all that documentation numerous times and submit it to multiple insurance plans. So this can be helpful. I have not tried these services, but I have heard of people in health departments that have used these and have had some success. So finally, lessons learned. I think it just takes time. You have to be prepared that it could take 2 to 3 months to work through a contracting process. They're not all the same. You can ask them if they have a public health contract, specifically, that's made a shorter version for health departments. They do exist out there. Your resources can be your other health departments in your area. Talk with them, share lessons learned. Designate that person in your office. Find that contact person within the insurance company. And overall, I think the reason we do this in wanting to contract is our financial success for our health department. So thank you.
Thank you, Robin, for a great presentation. Our next presenter is Vicki Poirier and Sharon Gates from the Mississippi State Department of Health. Welcome, Vicki and Sharon.
Thank you, Rebecca. We're going to share with you today how we've done some of these same things that Scott and Robin have both talked with you about, but we've done it from a centralized perspective. Here in Mississippi, we have a centralized structure, and by that I mean that our policies, our procedures, our billing decisions, and our contracts are all made at the state level, and then they're passed on to our 106 local county health clinics through our 9 public health districts that you see here. Our staff, just to give you an idea of our size, our staff includes 30 nurse practitioners, 25 physicians, approximately 400 nurses, and 300 clerks throughout our 82 counties. We use a centralized practice management system by all of our clinics statewide, and our billing and our claims information is entered by each county health department. Some of our claims are submitted directly to the insurance company, and then some of them are submitted through a clearinghouse. And then we have a centralized billing office that processes all of our claims follow-up. That includes our payments, our rejections, corrections, and rebills. So we do our billing from each of the county health departments, but we do all of the follow-ups in a centralized location. Once that billing information is entered in the local county health department, then the centralized billing office takes over for all of the additional processing and payment posting. Here in Mississippi, we've been billing Medicaid and Medicare for all of our eligible services, not just for immunizations. And we've been doing this for quite a long time. It's not required for us to have a contract to do that here in Mississippi. We do have an agreement with Medicaid for the allowable services and rates that they will reimburse. And then these rates are revised each year based on an internal cost report that we submit to Medicaid. CHIP in Mississippi is administered by the Division of Medicaid and United Healthcare, and we do have a contract in place with United Healthcare for CHIP services, and no credentialing was necessary for that. And you're going to hear more about our relationship with United Healthcare through this discussion. As we prepared to expand our billing to private insurances, we did the same things that many of you did and that things that you've already heard about today. We needed a way to keep up with the progress of all of our activity, who was doing what's the status of what's going on, and even though we're all centrally located, work was being done by staff from different departments, and it was difficult to keep up with what everyone was doing. We established a billing work group that meets monthly where we can talk about our current project status. And this work group is made up of upper management, including our state health officer and our chief administrative officer. This work group is actually made up of the people who can actually make decisions for the agency, and that's been very helpful in the progress of this project. We also began reviewing our current insurance coverage levels. As was recommended earlier, we developed reports to show us who we are providing services to and what insurance coverage they have. And these are very useful in determining which insurances we should bill. We collect private insurance information on all of our patients, even though we don't bill all of those insurances. And we report monthly how many patients and visits we have by insurance company. From that, we determine where we should focus our billing and our contracting efforts. And this is also helpful information when you're talking with insurance companies. We quickly discovered that we needed more resources to take care of this expanded billing. And while we had a centralized billing office that took care of our current billing, they would not be able to handle all of the additional activities associated with private insurance billing. So we added staff to help with the increased activities such as credentialing and the anticipated and desired increase in claims processing and payment posting. We also began establishing those important contacts that you heard both Robin and Scott talk about with our state insurance representatives and with other major insurance plan partners. I'm sure that you've heard before and that you're going to hear again how important it is to establish contacts and develop relationships with the right people. It can make this process much, much easier. We now have contracts and are billing or are very close to billing with these additional insurances that you see on this slide. United Healthcare and Magnolia Health are responsible for providing services for our Medicaid managed care. We have a contract with United Healthcare that's very much like our CHIP contract that I spoke about earlier. No credentialing was required for either of these because the billing for these is modeled after our Medicaid contract, or our Medicaid billing, which is by group, and it requires no credentialing. Now, for Magnolia Health, we chose a letter of agreement as our contract. We went this route because no credentialing was required for this, and so it would save us some time. We have a new contract that we've just recently, within the past month, gotten into place with Blue Cross of Mississippi, the AHS state network, and this is for the state and school employees health plan in Mississippi. We are billing and getting reimbursed for all of our flu and pneumonia vaccine and admin, along with some additional miscellaneous services that are provided to state employees who visit our clinics. And we also recently had mass flu vaccination of our health department employees, and we were able to bill Blue Cross AHS for the vaccine and the admin charges. We've also expanded our Medicare billing to include the Medicare Advantage plans, and we discovered that we do not need a contract to bill these plans. They are paying our billed amount, and they're paying for the services that were done back to last October through current date because they follow the Medicare guidelines of 1 year to submit and correct claims. And we've also had success with back billing for services for railroad Medicare for this very same reason. They too are paying for services that are provided October of 2012 through the current date. And then we like back billing, and so we're negotiating with our Blue Cross and AHS to get payments for last year's flu shots. We don't know what the final outcome will be, but we're talking with them about the possibility, and they are considering it. So we hope to get an answer soon from them. So in looking at our next steps, we are beginning contract negotiations with some additional private insurance companies. We chose Blue Cross Commercial because of the number of our patients that have this insurance. And even though we have a contract with Blue Cross AHS for the state employees plan, it does not cover Blue Cross Commercial. Blue Cross Commercial does not require that we have a contract. They just require that all of our physicians and nurse practitioners are credentialed. And we're in the process of gathering that information for them now. We chose to contract with United Healthcare Commercial, both due to our patient load, the number of patients that we have that have that insurance, and the fact that we already have 2 contracts with UHC. And we were told by a UHC representative that the contract for commercial would be a simple modification to our existing contracts, and we really do hope to find that to be true. Humana and Magnolia Health are the 2 insurance carriers with Mississippi's Healthcare Exchange, and therefore we chose to proceed with contract negotiations with both of these companies. In Mississippi, our contract discussion is initiated by our state health officer and our chief administrative officer. And then once they initiate these discussions, our third-party manager, our billing staff, and our legal staff join in for the actual contract negotiations. This same group of people deals with all of the contracts, and they know the process, they know what should be included in the contract, they know what the potential pitfalls are, and this has been very beneficial to us during this contracting process. Some of our additional plans at the agency are implementation of a new practice management system and electronic health record. We just recently signed a contract for these, and they should be fully implemented statewide within the next 24 months, and we are very excited about this. We are expanding our capability to verify eligibility, as Robin mentioned, the need for that. We are expanding our capability to do this through our practice management system. Eligibility verification is very important. If there's no eligibility, there are no benefits, and the providers are responsible for this verification. We will review the services that we offer and determine which ones are billable to insurance, and then we'll revise billing procedures so that we can bill and receive payments for the eligible services that we provide. And of course, there's always training. Training is always ongoing. So some of the lessons that we've learned and some challenges that we've faced and are still dealing with are listed here. Connecting with the right person. You've heard this one before. It's often very difficult to get in touch with the right person. We also get different answers depending on who we talk with. It's very important to find someone that you can use as your go-to person. For example, in our contract negotiation with Blue Cross of Mississippi, we worked with the Director of Provider Contracting. He was our contact, and he was our go-to person for Blue Cross and very beneficial to us. Communication with consumers and internal staff. It is critical that we communicate to consumers and internal staff while we're moving forward with private insurance billing. Getting the staff on board for this expanded billing is sometimes difficult. Additional training will be necessary for our staff to understand more about insurance copays and about deductibles at the local and the state level. And it'll be critical that the medical provider and the nurse providing the service in the clinic understand the importance of coding the service correctly. And we've learned how important this is with flu season and billing. Providing the correct vaccine based on what is actually covered by the plan is important in order to be reimbursed for the service. The insurance company lack of knowledge about our structure, and Scott touched on this earlier. You know, health plans are often not aware of the various medical services that are provided by local health departments. And there may be a misconception that medical services at health departments are free, and Scott mentioned this. We need to help our insurance companies understand how a relationship with your health department will benefit their plan. And in many cases, there's a health department in almost every city or county in the state. They will gain providers in every locality, often in their underserved or the rural areas in greatest need. So help them understand how they need you. Collecting insurance information from patients. Some patients are reluctant to share insurance information, as I'm sure that you've discovered. And we here are looking for ideas on how to overcome this challenge. The community perception that public health should be a free service. Have you heard this one before? I think we're all struggling with this. limited resources for coding and billing expertise. We have very limited resources within our agency for this, and trying to determine how to code flu this year was a very painful process for us. Confidentiality issues with EOB. This has been touched on just a little bit earlier. I think that many of us are struggling with this. We all know how important confidentiality is as a fundamental principle underlying the provision of health care. But the health insurance billing and claims processing procedures, for example, the practice of sending EOBs to a policyholder whenever care is provided under his or her policy, this unintentionally but routinely violates the basic guarantee for anyone enrolled as a dependent on someone else's policy. This is especially significant for those who are seeking sensitive services such as family planning and HIV. Sometimes these confidentiality issues are addressed in state statutes and regulations. The existence and the extent of these laws vary considerably across the states, and it's important for you to find out what the regulations are for your state. Sometimes they can be addressed in the contracts with health insurances, and this is still a challenge for us. We would love to hear how others are dealing with this problem. I hope that we shared something today that might be helpful to you, and our contact information is going to be shared later, and please feel free to contact us if you have any questions. And thank you very much for joining us today.
Thank you so much, Vicki. That was wonderful. So we just had a few tips here at NACCHO. We've spoke to a lot of our members about billing, and there are just a few things I'll go over quickly that they've highlighted. So one thing is if you have a legal department at your health department or in your county or even at the state level, it's helpful to have them go over the contract. Health plans like data. If you're able to show the health plan you want to contract with how many of their members are coming into your health department, that definitely helps you make the case in terms of their willingness to contract with you. Just make sure you're familiar with the language in the contract and everything that's included. Certain things like auto renewal can throw in things that you didn't necessarily agree to in the beginning, so just be careful. And back to the first point, a legal counsel is really helpful. And then Vicki just mentioned the confidentiality. It could be an opportunity for you to negotiate confidentiality and the suppression of the explanation of benefits around confidential services during this process. So just know that you are able to negotiate, and the first contract isn't what you're left with. You have some room to get what you want and play around with it. So real quick, because we have received a lot of questions and answers, we'll just show you NACCHO's Billing for Clinical Services Toolkit. In our toolkit, we have a number of resources that touch on billing in general or go into specific programmatic issues, and there are a lot of different tools for the contracting process. There are things like a script about how to talk with private insurance representatives, model contracts. There's even a sample survey that the New York State Department of Health is using to assess what payers are coming into the clinics and then see if the patients are willing to bill their insurance plan for these services. So there are a lot of great resources there that you can customize for your health department and that can help make the contracting and the billing process overall a little easier.
Here is a list of general billing resources. We have our billing website at NACCHO, our toolkit. NACCHO Exchange, the summer edition, it was the public health law focus, but there was an article on the Arizona billing project and related to changing state laws. Then we also have the CDC Billables Project for Health Department Immunization Services reimbursement website. There's also PH Connect, which is the community of practice, and you can talk to other local health departments and ask questions and bump ideas off of each other. Then there's also a great case study from NCSD, Shifting into Third-Party Billing Practices for Public Health STD Services, Policy and Contact and Cases. And then finally, the Family Planning National Training Centers has a resource called Revenue Cycle Management, Contracting with Payers. So those are really good and helpful resources. Here are our contact information, so if you have any direct questions specific to our speakers, please feel free to email us and we'll try to follow up with you. And now this is the time for you. We've been watching the questions coming in, and there's actually quite a few, and we'll try to answer as fast as we can and as many as we can. And if we don't get to your question today, we'll be sure to send out a question and answer document with the slides and the recording of this webinar. So if you have any specific questions, please use the chat feature, which I think most of you are aware of, on the lower left of your screen. And also, before we continue on to questions, I just want to remind everyone that there is a post-webinar evaluation. So please leave your window up, and it will come up, and it'll take you less than 3 minutes to complete. So we have a few questions, and the first one is?
So this one is related specifically to Scott's presentation, and he touched upon government sovereignty. And Scott, if you're able to just expand a little bit more on what you meant by that and how that relates to the contracting process, that would be wonderful.
Sure. Often insurers will put language into their contracts in the case of a financial dispute. And essentially what that does is lay claim to the provider's assets should there be a dispute, and should that financial dispute not be something that the provider can pay. And governments, of course, have a problem with anything that infringes upon their sovereignty. In other words, their ability to determine the use and the disposition of anything that belongs to the government. And so that kind of clause would not be something that the government would allow in the contract. And that's something that either the county or the state lawyers are going to take an interest in and ensure that the language is appropriate for contracting by the government.
Thank you, Scott. There was a quick question about Mississippi, the electronic health records and the practice management system that you're using. So if you want to briefly touch on your state PIMS model. Vicki?
I can do that. We are currently using a system from Siemens. It's called Signature, that we have been using since the early 1990s. And so that ought to help you understand why we are so excited about this new practice management and EHR system that we have just contracted with. The Signature system will be replaced for us with the next gen product, and we're using both their practice. We will be using both their practice management and their EHR system.
Thank you, Vicki, I'm sorry. Robin, the next question will be for you.
So there was a question about whether or not it's better to establish a limited contract for specific services, such as a contract for STD services, a contract for a vaccine, or if you should establish the contract all at the same time and more health department-wide. Do you want to speak to that?
I can. I think we've kind of done that both ways here at our health department. And it kind of depends on how many clients you may have coming in for that specific provider. So initially, we might have formed the contract in the Title X area, but now we're seeing a lot of users maybe coming in for immunization, so we've added that. Most of the time when I've tried to do a blanket contract, I still end up going back on the Title X family planning side and providing additional information or additional documentation, because we have a nurse practitioner that works in that program that is here on site. So most of the time you do end up doing two separate things.
We have another. Thank you, Robin. We have another question. Hold on one second. There's a lot of questions coming in. So there's a question, and whoever can answer this, feel free to go ahead. How are you handling billing directly to patients without insurance or with large copays or deductibles?
This is Scott. I guess I will jump in. Although I work at the state and we do not directly, our policy is that the health departments should each have a cost-based fee, and that fee is collected as appropriate. However, we do use sliding fee scales, and the county health departments in our state have the authority to waive fees as necessary. Generally, those those are intended for the uninsured. However, the county health departments have the authority to set up their sliding fee scales and apply them generally as they see fit.
Thank you, Scott. There's another question about policies and procedures developed to bill third-party insurance contracting, and they were wondering if you have any example about specific policies and procedures you've established to help with the contracting process at your health department.
And if you could share those later, and we may be able to add those to the NACCHO Billing for Clinical Services Toolkit, but we can definitely highlight that to our participants on this call.
If you have any just examples of around what areas the policies and procedures were established?
Well, in New York, we didn't so much establish policies and procedures as when we started up the project, we did a lot of research to determine what policies and procedures were out there, and to see how those could benefit or hinder the process of county health departments to bill.
Thank you so much, Scott. And then one more question, Vicki. I think we spoke about this before, but someone was asking about how do you go about billing an insurance company that you do not have a contract with? And so are you able to speak to billing someone that you haven't established a contract with and be successfully reimbursed for this?
I can do that. And what we did was we actually just sent them a claim. We didn't have to do anything to get established. We just sent an insurance claim out of our electronic system and waited to see if they paid. And when they didn't reject it and they sent us the full payment, we started sending more claims. I'm sorry, that sounds so simple, but that's what we did.
Yeah, this is Robin, and I would have to ditto. That's exactly how we did it as well. I've actually even had clients send in a receipt to their own insurance company requesting payment. Our practice management system does allow for codes now to be put onto the bill, so that works out well. But I remember the day of handwriting a receipt saying that they paid for a service, and they sent that to an insurance company, which then contacted us to ask, well, what was it that we provided?
Also, the state of Ohio and also New York City has developed surveys that you give to your patients when they come in the door and ask why they're coming in, if they're insured, if they are insured, what are their insurance companies, so you can get an idea of what third-party payers your clients and patients they have that are seeking services with you. So that's a good idea and starting point. And those types of surveys and examples are in the Getting Started section of our toolkit. So we have one more question. And Alyssa?
Sure. I think this is a question probably everyone might be able to speak to, but it says, to what extent do we think local health agencies have the capacity to make this transformation, especially since we have been moving towards, in the past several years, focusing on the social determinants of health? So just kind of that dichotomy between making sure everyone has access to services, but then getting reimbursement and having sustainable health departments.
I'd be glad to jump in and say just a couple of words. In New York State, we've tried to emphasize the fact that it's a balance between charging appropriate fees and getting appropriate reimbursement, and ensuring that we're not reducing access to those individuals who cannot afford to pay for the services, who do not have insurance. So it is definitely a balancing act, and in my experience here in New York State, we've had a number of different counties with different experiences. Some of them were really early adopters getting in. Some of them were already billing, and I think that it is a mindset change, but it's something that counties are going through, and they're doing quite successfully. And it does help them cope with the changes that are ongoing in the financial world of public health.
Thank you, Scott. And on that note, I think we'll end today's webinar. We would like to thank all the participants for joining today, the CDC, and especially our presenters, Scott, Robin, Vicki, Sharon, Alyssa, and thank you so much. Finally, please keep your window open. Once we stop the meeting, an evaluation will pop up. And once again, we will send the answers to the questions you sent us that we couldn't answer today with the slides and the recording later. Thank you again, and hopefully you've learned a little bit about contracting and billing at the local health department perspective. Thank you, and have a wonderful afternoon.
Thank you, ladies and gentlemen. That does conclude today's webinar. We thank you for your participation and ask that you please now complete a post-webinar evaluation. Thank you, and have a great day.